Hello, I'm Steve Buck, Chair of the Department of Psychology here at the University of Washington. The lecture you're about to see is part of our annual Alan Edwards Psychology Lecture Series. Professor Edwards was affiliated with the Department of Psychology for half a century until his death in 1994. He was an outstanding teacher, researcher, and writer who introduced new statistical techniques that are credited with changing the way modern psychological research is conducted. Alan also permanently enhanced the intellectual climate of UW Psychology by endowing the Alan Edwards Lectureship, which since 1999 has brought an impressive list of renowned psychologists to the UW campus to interact with faculty and students. Now, the annual Alan Edwards Psychology Lecture Series presents the excitement of psychological research and its tangible benefits to both local and national audiences. The lecture you're about to watch is one of a pair given back-to-back that matched a UW Psychology faculty member with a visiting researcher to talk about a topic of great public and scientific interest. Good evening. I'm Steve Buck, Chair of the Department of Psychology here at the University of Washington. Welcome to this evening's continuation of the Alan Edwards Psychology Public Lecture Series. This series is presented by the Department of Psychology, the College of Arts and Sciences, and the University of Washington Alumni Association, and is funded by a generous endowment from Alan Edwards. The topics in this series illustrate how psychological research serves humanity. The University of Washington receives more research support money than any other public university in the country, topping $1 billion this past year. The Department of Psychology alone receives almost $10 million annually in research funding that helps us advance our knowledge of basic science, directly serve people in our community and around the globe, and train our undergraduate and graduate students. Tonight's lecture addresses the promise of prevention for conduct problems in at-risk youth. Our speaker is Dr. Patrick Tolan. Dr. Tolan is professor of psychiatry at the University of Illinois at Chicago, and for the past 9 years has served as director of the Institute for Juvenile Research. During that time, the Institute has become one of the largest research, training, and innovative service centers in child and adolescent mental health in the country. Dr. Tolan is an internationally recognized authority on violence, adolescence, families, and prevention. For the past 20-plus years, he's conducted research with multiple collaborators on risk contributors and methods for preventing disruptive behavior, delinquency, and youth violence. And he's worked to link policy to science in children's mental health. He's author or co-author of more than 100 books, monographs, chapters, articles, and technical reports. Dr. Tolan received numerous professional honors, including the 2007 Star of Science Award from the Children's Brain Research Foundation. He's currently president of the Society for Child and Family Practice and Policy, which is within the American Psychological Association, for which he's also recently headed a director's task force on developing psychology's national agenda for children's mental health. Please join me in welcoming Dr. Patrick Tolan. Thank you.
Good evening. It's a real pleasure to be here and to have this opportunity to speak with you. My hope tonight is to talk in a broad way about the issue of conduct problems in our society and to complement the other program that focused in depth on a specific approach to this problem. My hope is that whatever brought you here tonight and whatever is bringing people to watch this program, that what you'll have at the end of this is a way of understanding the problem and to be thinking about what you want to do either in your professional or in your personal life to help try and address this very important social problem and problem of children's mental health. I'm going to talk a little bit about children's mental health and then talk about conduct disorder specifically and then to start to talk about what we know about the problem and what we know about what we can do and then what we don't know yet. I'm at the Institute for Juvenile Research, And the Institute for Juvenile Research was where, a little over 100 years ago, a group of people said, if we're going to understand children, we have to understand how they develop. And if we're going to understand their problems, we have to use science. And that's what has been going on for 100 years, has now spread around the country to be a focus on science as a way of helping us understand children's problems and of helping us direct policy. And that's what the focus of tonight's talk will be about, and that's what I hope that you'll see the Institute's work and take with you the idea of how this might be useful in trying to address this problem. Children's mental health is a broad problem within which conduct disorder exists. And it's a problem that has major impact that's unrecognized. The current best estimates are that at any given time in this country, about 20% of the children are trying to deal with, and their families are suffering from, a diagnosable mental disorder. Not just some distress, not just they're unhappy, but a substantial disorder that affects their functioning and impacts their health. And that over the course of lifetime, about 50% of the population will have some significant episode of mental disorder. So in that way, it becomes the most prevalent medical or health problem in this country. It also, for under age 18, is the second largest health expenditure in this country, largely unrecognized. If you ask people that, most health policy people would not tell you, oh, it must be that. But it turns out it is. We spend about $9 billion a year in this country on mental health-related treatment for children. It's also one of the most hidden healthcare costs in other healthcare expenditures. About 60% of parents' visits to see their pediatricians are prompted by concerns about development or about behavior. It's what's referred to as the runny nose excuse, which is that parents need an excuse to get some help, and pediatricians and other healthcare providers need an excuse to see these people and give them some help. So it's something about a runny nose or some problems with their stomach, but it's really a conversation about what do I do about how they're behaving, what do I do when I lose my patience, what do I do if they don't seem able to do the things that my other friends' kids can do, and those sorts of questions. So it's a hidden health cost in addition to the direct care for mental health problems. It's also a hidden educational cost. It's the leading reason, until recent, it was the leading reason teachers said that they left the field was because of the problems of trying to manage behavior in the classroom. That has now fallen behind the onerous task of test taking, but it's still the third leading cause of why we're losing teachers. We lose about half of our teachers within 6 years of beginning. And if you want to think about health of costs and lost opportunity of losing half of that trained group of people every 6 years, you can imagine the impact. It's also one of the leading reasons that of lost lives of children. For people under 18, depending on the year and depending on what else is being measured, suicide is either the leading or one of the top 3 causes of death for children. And suicide is almost always related to depression and other mental illnesses. And it's not just an issue of lost lives or additional costs. There's a huge impact on the economy in lost productivity. So one survey showed that parents of children with mental health problems were less productive at work. Just imagine when your child has a flu and how you work that day versus the days when they're healthy and they're in school and they're doing what they're supposed to. So now imagine your child has a flu every single day. And imagine the effect that's going to have on your ability to work, your choices about what you might do, whether or not you can stay late at the office when they need you to help, or whether you can manage things differently in terms of being able to be more focused and more able to do your work. So there's a big impact on the productivity of parents, and then there's also these children don't grow up to be fulfilling their potential, and the lost productivity and capabilities they would bring to our society, those are gone too. Conduct problems are a major part of child mental health issues. It's the most common problem. It's the most common form of mental health problems. It's the least accepted as mental disorder. 20 years ago, there was a belief that children could not become depressed. There was no such thing as child depression. And if you were a parent who brought your child to a mental health clinic and said, my child's depressed, you were told there's something wrong with you because children don't get depressed. We now recognize that that's absolutely not the case, and in fact, it's a significant problem for many children. Well, behavior disorder and behavior problems are much like depression was 20 years ago. People don't believe it's really a mental health problem. It's misbehavior, it's parents not having good morals, it's our society not caring enough about children. There's lots of reasons that are given to say that this isn't really a problem that fits into the thinking of mental disorder. It's also the problem among mental health problems and child behavior problems that has the most costs, and I just went through some of those on the previous slide, but these costs expand out because they affect not just health care, but educational and criminal justice costs. Conduct disorders and conduct problems are also important because childhood conduct disorders predict most of the major mental illness and social problems of adulthood. Yeah, and so if you want to understand who's at risk for lots of problems from, even schizophrenia is predicted by conduct problems as a young child. We don't know why, but they do predict. And so we see this problem seems to foretell a lot of problems later on in life, and doing something about it could have a big impact on many areas. It also predicts worse functioning when it co-occurs. So for any child who has another kind of mental health problem or an educational problem or a family problem, the presence of conduct disorder predicts poor functioning, poor prognosis, and again, more cost and needs and difficulties. And lastly, it turns out that it is apparent earlier than we thought. I mentioned about 20 years ago, people didn't believe children could be depressed. And the current belief, I'm sure you've all heard about the terrible twos, and you've all heard that you can't have a conduct disorder until you get into school because children's personalities aren't formed enough. Their behavior patterns aren't set yet. You have to have a lot of bad things happen before you become a conduct disorder. Well, we're starting to discover that that may actually not be the case, that we didn't have ways of telling the difference between what is a child who's going through a normal developmental period that occurs in preschool where you start to get less and less aggressive and you learn to control yourself, and these children who are really expressing what is going to go on to be perhaps a lifelong problem, or at least a long-standing problem in childhood. So we're starting to recognize that it could be identified earlier and that it may be something that's expressed from early on rather than it develops and is an accumulated problem due to multiple risk factors only. So what are conduct disorders? They have four main features when you're talking about conduct disorders. The first is a tendency to use aggression, to be more aggressive than others in social situations, to resort to aggression when you're facing conflict or frustration, to see aggression as an effective and good way to manage problems you have in life. The second aspect of it is noncompliance. So these are the kids that are asked 3, 4, 5, 6, 7, 8, 9, 10 times to do something in school, and they don't do it, or they don't pick up the toys, or they don't stop bothering their sister. That's noncompliance. Temper laws. These are children for whom frustration and difficulty leads to serious temper tantrums, if you will, but continuing on much past the age when normally children would age out of temper tantrums. And the fourth aspect of it is a lack of concern for others. So you see often in children with conduct problems, they don't seem to be upset by transgression. They don't seem to be upset by perhaps hurting somebody else or stepping on the toes and rights of other people. And they don't seem to show the kind of guilt or remorse that you would see in most children. The current diagnoses that are used for these are called oppositional defiant disorder, meaning that you are defiant, you refuse to do what you're being told to, or conduct disorder, meaning that you engage in behavior that transgresses the rules and regulations that we have for children, expectations we have for children in terms of compliance. Oppositional defiant behavior tends to be identified more in preschool children and conduct disorder more in elementary school children. but I think we're probably moving to where that's really going to be recognition of the limitations of the assessment approaches we've had until recently. It often co-occurs with the other very common child mental disorder, which is attention deficit hyperactivity disorder. And this is where children have trouble concentrating, of directing attention, of not being distractible, and of being able to sit still in the sense of being able to stay in their seat and continue an activity that requires self-control and bodily control for a period of time, as we often do. And that's why you often see this come up when children first go to schools, because that's when they're often first asked to maintain that kind of ability to sit and pay attention and keep focus and so on. And that often co-occurs with conduct disorder. What are the patterns and effects of conduct disorder and conduct problems? First, it runs in families, as do most characteristics, whether that's playing piano or having a tendency to not be able to hear well. There's lots of characteristics, and most of those run in families and probably are carried through some kind of genetic tendency. However, the best information we have about genetic loading for conduct disorder is that among the mental disorders, it's one of the least genetically transmitted. We don't have good information, but the information we have, that seems to be a way that it is looking for this disorder. So it's not a particularly genetically transmitted disorder, but it does tend to run in families because families also transmit cultural practices and ways of acting with each other and moral values and lots of other ways of continuing across generations besides genetic characteristics. It's thought to form by elementary school, so usually it's identified in elementary school, although there are some children for whom this disorder is not evident and doesn't seem to be on display until adolescence. And what we're recognizing now is that there are preschool children for whom this is the case, and that intervention earlier on could be possible, as well as identification of the need for intervention occurring earlier. It has a higher prevalence in males than females, about a 2-to-1 to 3-to-1 ratio in males and females. This seems to cut across cultures, even though the disorder itself changes in prevalence rate by cultures. There does seem to be a higher rate among males. And what are the major predictors of this? Well, the major predictors are known in some ways, but they're starting to be understood a little more carefully and a little more in depth, and they're starting to rethink some of what we thought we knew, and it's more of a fine-tuning. So for the idea of temperament, the belief was, and the evidence seemed to indicate, that children who had an irritable temperament, that were difficult to soothe, that were hard to settle down, that these were the kids who were more at risk for serious conduct disorder. But there's some recent studies that suggest that it might be children whose temperament is actually more of a lack of responsiveness rather than a quickly irritating kind of response, that are more likely to show the predisposition in developing conduct disorder. So it may be this lack of response to other people that's making children at risk temperamentally rather than a quick to respond and a hard to soothe temperament. Secondly is that there are cognitive limitations in their ability to manage social relationships and in their problem-solving skills. This difference in problems in social relationships is not that they don't understand social relationships or that they don't have an interest in people, as occur in some child psychiatric problems, but that they actually see these relationships much more contentiously. They have a presumption that, for example, other people have hostile interests when they don't. They may be more likely to see conflict as something that's about getting your way or somebody else getting their way rather than solving problems, trying to find a way to work it out, so to speak. And so these social skills programs that are done focus on helping to deal with those differences, those biases, those misunderstandings of social relationships and social problems. And then they have deficits in problem solving. That is that they're not good at thinking of alternatives. When you say, what would you do in this situation? They have a hard time coming up with more than one or two solutions. They come up with solutions that involve aggression. They come up with solutions that involve somebody forcing somebody else to do something rather than perhaps sharing or taking turns or other ways that children and adults can work out conflicts they have. It's also predicted by parenting practices. Parents who use what are called coercive parenting practices, that is, they use discipline that is inconsistent. So some days you're in trouble for doing something, the next day you're not. Some days you're praised for something, the next day you're not. Parents who use harsh practices, and harsh and inconsistent tend to go together. Harsh parents are people who suddenly explode, and are very intense, and that intensity doesn't seem to have to do with the level of transgression. So it could be that you didn't pick up your clothes, it could be that you flushed your brother's cat down the toilet. But those two things would get this equal kind of parental response potentially, and it doesn't seem to be related to the behavior. So the child is learning that punishment is not related to the behavior. Similarly, on the good parenting side, there's a limited monitoring of the children. That is, when they're preschoolers, literally being in the room and watching them and helping them learn safety and management and moving about in space and how to talk and how to hold each other and all these things that we teach infants. When they get older in preschool and elementary grade, it's more of knowing what they're doing and keeping your eye on them and letting them not go too far. And when they get into adolescence, it's knowing who their friends are, where they are, what they're doing with them, when they should be home, whether or not they got home on time, and that kind of keeping track of them. And so those parenting practices have all been shown and implicated to be related to conduct disorder. Experience of abuse and neglect. Children who have been abused and who have been neglected are much more likely to have conduct disorders than children who haven't. And the severity of the abuse in particular seems to be important. And then poor peer relationships. And it's not clear whether poor peer relationships are generated by these children. It seems that they're very good at getting other kids to not like them and to be aggressive and to be rejected. But it also looks like this risk is related to involvement with other kids who are delinquent, and particularly the adolescent involvement in conduct disorder. Going back up and moving from conduct disorder to mental health in general, because conduct disorder is really an example of what is a crisis in children's mental health in this country. I explained to you the high rates of mental disorder and needs, and that's just a part of the issue because that's just children with mental disorders. That's not reaching children's mental health needs in general. It's not preventing, it's just recognizing and identifying. And conduct disorder is an example of that. At present, there is a lot of debate and a lot of what I would call infighting among advocates for children's mental health about which is more important. Should we treat the kids who have disorders, or should we work for prevention? Should we try to identify something that helps children in general and we can put it into our social and educational fabric, much like we have fluoride in our water to prevent dental caries? Or should we try and find those high-risk children, those who are in very bad situations or have this temperamental tendency, and work with them and intensively focus on them? These are very bad contentions. They're not bad because everybody has to go to a corner now for misbehaving. They're bad because they are creating contentions when in fact they're both pieces of a puzzle. And if you will, they're fighting over pieces of a pie when the real problem is the pie is so small, it's not really fighting about it's not the issue. We spend a very negligible amount of our funds on children's mental health. There's nothing in proportion to the need or to the health impact. It's way below what would be reasonable to do by most analyses. And primarily that is in part due to the fact that it's not recognized the critical role it plays or the many ways it could be intervened with. These are four components of what probably are needed if we're going to have an effective mental health system. If you want to, if you will, the pie that needs to then be debated about how big should it be and what should be in it. The first is promotion of mental health itself and good child development. We know a lot of things about what is important for children to have to develop a good sense of capability, to feel like they belong and should adhere to the rules and the mores of our society, that they should care about and should take care of their family and expect to be cared for, why they should try and achieve in school. We know a lot about how to do that, and that promotes mental health. That decreases the risk for mental health. So just in child care and in helping people who are parents and becoming parents, and in our schools and the way we train our teachers and run our classrooms, there's promotion of mental health and child development. What are called universal interventions. These are things that, given to everybody from a public health perspective, decrease the risk. So vaccinations for example, are universals. We give them to everybody, irrespective of your genetic probability of ever having polio. We give that to you because the effects are enough that we want to make sure everybody gets it, and the impact is powerful enough that it's worth it. And so promotion of mental health is a universal that would help address some of these issues. There's also a need for opportunity for consultation and support around mental health issues in a couple of forms. I mentioned the runny nose excuse, so that one doesn't have to have an excuse to get advice. And one is, as a healthcare professional or as a mental health professional or child development professional, you don't have to have an excuse to take your time and use that time to help a parent with these issues. To be able to have healthcare professionals get paid for the time they put into answering these very important questions, and to have parents understand that they don't have to know all these things, and that there is help that can be gotten and access to that. Another way that mental health consultation or support can be promoted is by decreasing the isolation of a lot of parents. There are a lot of parents, particularly who live in high-risk situations. They're young parents, or they're economically poor, or they're not very connected to their family and other people, so that they were raising children sort of by guesswork on their own. And it's not so much that everybody else gets it, it's that everybody else is raising their children with lots and lots of help. There's an African saying that no one raises a healthy child alone. And it turns out that social network research, that's research that looks at how we're all connected to each other and how we help each other, shows that that's true. Most people raise their children with lots of help. Parenting is usually done in an embedded social network of people who give you advice. So when your parents or your brother or sister are giving you that irritating advice about how well they raise children, and if you did it the way they did, everything would be fine, that's actually a good thing, because it's helping you understand how to raise children. It's giving you information so you make fewer mistakes. In addition to that general consultation and that promotion of mental health, there's a need for people to be able to get prevention and early intervention for at-risk children. There is differences in who's at risk, whether you look within a particular population or whether you look across society at different segments of the population. And there are promising prevention efforts out there. I'm going to talk about those soon. And there are lots of opportunities for high-risk children, if they could get access to these interventions, to have the risk stemmed, to have the prevalence decrease, the number of kids who wind up with these problems, and have the difficulty and harm they cause to themselves and to us prevented. And then there is a need for treatment and rehabilitation. There's going to be a continuing need to support and manage children and families who have mental disorders and who are going to have lifelong issues related to that. Most mental health problems have some kind of effective interventions for at least managing them, but they involve often long-term management, even if the management is to make sure it doesn't happen again. So there is going to be a need for those services and for effective services of those sort to be accessible. We have an evidence base for effective approaches. We certainly haven't gotten to the promised land in this area. It's not a matter of we know these are the 6 things we need to do and we just need to get them to children and families. But we have very promising findings. And when you take the findings, the empirical base for the work that's done in children's mental health, and compare it to other healthcare areas, it's as strong as it is in most other areas. I don't want to frighten you about other healthcare, because the empirical base may not be as strong as we presume. But I want you to understand that for children's mental health, there's a relatively strong basis for the contentions that we know a lot about what to do, and it's really a matter of getting the services and getting the programs to children and into society and into communities and schools than it is that we have no idea what to do and nothing works. We have empirically tested programs. We have protocols that, when followed, make a difference. Children's mental health, until about 10 years ago, prided itself on not following protocols. We knew what kids liked, we loved them, And we just had great hearts, and as long as we followed those, we'd make a difference. Well, what we discovered is, in fact, in some cases, we not only weren't helping them, we may have been hurting them by just following that heart and that great care. And we now know that there are programs that work and there are programs that don't work. And so by following those protocols, we're starting to see some real differences. We're developing scientific methods to understand what works and what doesn't. So when there isn't proper controls, 83% of studies of interventions show those interventions to be effective or look like they're effective. But when you actually require the basic kinds of controls we require in science to know whether or not something is probably true or probably false, only about 25% of those same programs will look like they're working. And so it's applying these controls are very important. They're not just things to employ professors. They're not just picky things that scientists insist on. They make the difference in what kind of health care children are going to get. We have programs that have substantial and lasting effects that show reductions in prevalence 10, 15 years later. We have programs that show effects that go away, and we have lots of programs that seem promising that don't show effects, but we do have evidence of long-term effects. Now, I want you to remember, when the National Cancer Institute decides a cancer treatment is effective, they say that means 5 years from now, you won't have had a reoccurrence of cancer. If it happens on day 5 years and 1 day later, it still is effective. We're talking 10, 15 years later. So the standards that are being applied here are also often very stringent. And people will say, well, it only lasted 8 years, or 7 years later we came back and the problems seem to still be there. When in fact, we're not doing that we're not creating those kinds of standards in most other areas to decide these things are valuable and worth spending our time and money on, and they make a difference. We're also beginning, though, to recognize that a lot of these good ideas can be harmful, and it's critical to apply scientific approaches to understand that. So one of the findings that's come out, particularly in the last 10 years, but actually the first evidence of it occurred almost 35 years ago, in one of the first really good scientific efforts to try and see if we could do something about delinquency. And that's that what we thought was good, which was to put kids who are delinquent or high-risk delinquents together, just get them together in a small group and teach them positive values and model that for them, show them how to do it, and reinforce it, tell them they were great when they did it. Well, it turned out when we weren't looking, what they were doing was teaching each other new tricks about how to be delinquent and secret ways of doing things. And so what was going on is what was called deviancy training. And in fact, these kids were becoming more likely to be delinquent put into these groups. And that approach drove a lot of policy and a lot of intervention for many years, and still is a prominent way of working with kids who are high risk for conduct disorder, when in fact there's about 5 studies now that have shown clear negative effects. The kids get worse. And DARE, which is a very popular program for prevention of drug abuse, there's been several studies, I think there's about 3 or 4 now large studies that have attempted to look at the DARE in an objective way and have consistently shown that either it has no effects or, in fact, in some cases, primarily in suburban and middle-class neighborhoods, it has some negative effects. And so the idea is that this is a program that actually everybody believed in. People believed in it and to where they were putting billions of dollars in it. And if you looked at it, it looked like it was doing things that we would say are good things to do. It wasn't until we actually tested it carefully we saw the difference. So I'm going to talk now about some of the programs and approaches that seem to be promising. And if you start to see a Seattle focus here in my talk, it's not that I did this because I was coming to Seattle. It turns out that you are actually in the heart of a lot of the most critical work and where the advances are occurring in regard to both what programs can work and how those programs might be used in practice and how your legislature uses science to make decisions. So for example, this is one of the few places in the country where evidence-based information is regularly brought forth and actually used to implement programs. It may not be occurring to the level that advocates would prefer, and it certainly isn't occurring to the level that we would like to see if we wanted to. but it's occurring in a way that's ahead of the rest of the country. Early childhood education, organized programs like Head Start. Now there are programs, early childhood education programs that are not effective, but programs that involve parents, that are structured, don't have too many kids in one room, and focus on helping kids with what are called pre-literacy skills, particularly in high-risk communities, show benefits in terms of lower rates of aggression of those children. And some of these findings go out to in adolescence. Behavioral parenting programs. There's one that started here that's called the Incredible Years. These are programs that in parent groups and through videotapes and other methods teach parents ways of managing behavior and responding to children's behavior that show that they reduce the likelihood of aggressive behavior in the children. And as you get older and move up into middle school, somebody was asking about middle school and elementary and into middle school. One example of this is the social development program, social development approaches. Two of those are the Seattle Social Development Program and the Positive Choices. And these are programs that focus on helping children with decision making and bonding to school and conventional roles and to choices that are related to essentially not engaging in antisocial behavior, not engaging in drug taking, other kinds of risky behavior. And it's a problem-solving skills and related work. And those are universal programs. Another one is what's programs that focus specifically on social skills, which are, again, these ability to solve problems in social relationships and to understand how to manage those, peer pressure being the prototypic type that you've heard about. So what do you do when your friends are trying to get you to do something that's probably not good for you? And it's training in that and rehearsing the behaviors and then trying to work to help kids to apply it in a couple of situations so when that situation comes up, they'll have some skills that they're ready to use. If we go from these universal programs up to the level of higher risk kids and selecting kids based on either living in high-risk neighborhoods or having families that have problems in parenting skills, or because the children are showing academic and behavioral risk characteristics, we also have some effective programs out there. A program that we worked on and is designed for communities that are very high poverty, high crime communities, and are focused on helping parents to raise children within those communities to do well in school and to reduce aggression, is called Supporting Families in High-Risk Communities or Safe Children. And this program shows that parents of the children in these programs, parents that go to these parents groups and the children get reading tutoring, their kids do better in school, the parents stay more involved in school, and the high-risk children and high-risk families among this population show improvement in parenting and in the child behavior. Programs that help children deal with anger management, a program called Coping Power. This is a program that helps children think about what to do when they're upset or when they're angry and how to deal with the feelings and what might be ways that they can, if you will, mediate the anger feeling and then decide what to do. Also works on skills that help them less likely to get into those situations and less likely to have that kind of strong reaction to normal kinds of daily social issues. And then programs that link high-risk children and students and their parents to the schools and work on what are called parent-school programs for high-risk children. For example, there's a common part of one of these programs would be what you have is called a daily report card, which is that the child brings home daily what they're supposed to do. The parent focuses on making sure they do that and it goes back to school. It greatly increases the communication, also greatly increases the opportunity to reinforce positive behavior, and also greatly increases the opportunity for the child to see real practical benefits of doing what they're supposed to and of trying to achieve in school. We also have a roster of, an increasing roster of programs that have shown effects for conduct problems. One example is what's called parent-child interaction therapy. Parent-child interaction therapy is guided work with a child and a parent on issues of monitoring, of behavior management, of positive response to the child, and of parenting skills. The non-compliant child program is an example of that, working with the non-compliant child. Programs that focus on cognitive behavioral training. Remember, I talked about the problems that these children can have in social cognition around social relationships and conflict. And pairing that up with behavioral parent training, which is a program that works on helping parents to learn how to track and manage and reinforce their children's behavior, positive behaviors, and to ignore and help end negative behaviors. Functional family therapy. And the programs I'm listing on this, you're seeing now come up on the screen, these are programs that work with increasingly serious and older children would be the way to understand it. Functional family therapy is an approach to family therapy that focuses on establishing a positive relationship between the provider and every person in the family, and then to try and improve the communication among the family members and create ways of setting up rules and communication skills that help improve family communication, but also create very clear expectations for adolescents and for the parents, and allows that to guide the family behavior. Multisystemic therapy is a program that works in the home and works with the idea of very high-risk families, but working with all the systems that might impact on a child's life, and working with anybody in the family and the child's life that can help with that. So they may work with schools and juvenile court and child welfare, but they may work with an aunt, or as well as the mother and father, anybody who can bring to bear some capabilities to help set up a system that provides a child with the protection they should have, the guidance they should have, and the opportunity to see positive behavior and in role models. And then as you move up the track towards more serious, there's a program that was actually developed for families who are have children in foster care. And it's training families with children in foster care to engage in some of the similar kinds of activities as are done in multisystemic therapy, but with a focus specifically on foster care situations and the complexities of dealing with the foster care system and the often very difficult, demanding needs of some children in foster care. So it's meant to help those children be able to stay in the home, help those parents be able to manage the child's needs and get them under control so they can have the stability in the home. And the foster care parents can stay with the being foster care parents. These programs are not just effective in the sense of we can show you some statistical difference, or I can show you that a smaller percentage of these children will have clinical disorder than those who didn't. They also have a cost effectiveness in the sense of we are going to spend this money on these children one way or the other, and we can spend less or we can spend more. And this shows you how much more we will spend if we don't use these programs. So for example, here's the Seattle Social Development Program. If you calculate the benefits of the child not being in court, of not needing as much special education, of being more likely to finish high school, of being more likely to be employable, you see about a $14,000 benefit with an estimated cost of delivery of that program of about $4,500. So net savings about almost $10,000, or about $3 for every dollar invested. So I don't know how many of you make your living doing investment work, but that's pretty good return. There's very few investments you can bet that you're going to get 3-to-1 return on. And you could see these other programs, the Nurse Family Partnership for Low-Income Children. It's a very well-regarded program in which nurses meet with mothers, young mothers who have had their first child, and work with both helping them with becoming a mother and managing the child, but also being a woman growing up and how do they manage their life now that they are a mother. And then parent-child interaction therapy, which I mentioned earlier. So all of these programs show a very nice return on the investment. Another way to understand that is that's $3 to do something else that we're now spending on these programs, and we can't do that something else because we're spending it on these children, because chronic mental health care, juvenile justice, and special education costs are there. And health care costs, they impose on us. We don't get to decide to spend that money. That money gets imposed by law or by fiat or by tradition, or because nobody wants to be the person who didn't support the psychiatric hospitals, for example, or didn't support building prisons when there's a crime problem. So this money gets spent, and all this is an opportunity to spend it more wisely. Now, this is what we know, and this is the promise that's there, and this is what could occur. But this is not what's occurring. And the reason it's not occurring is complicated. There's a list here, and you'll see them as I go through them. That much of it has to do with understanding and information, but some of it has to do with recognizing that these are real problems that could and should get attention. Less than 30% of those children with a diagnosable disorder will get mental health care. So only 1 in 3. So imagine if, again, go back to polio, and we just said we're only going to treat 1 out of every 3 cases. Probably wouldn't be able to do much about the impact of that on our society. There's limited use of the empirically tested programs in practice. The practice out there generally has no financial incentives to use these. You get paid as much for doing whatever you happen to feel like doing as you do with one of these proven programs. There's limited professional requirements to use them. None of the major mental health professions require that people use only empirically based programs or give some justification for going outside of this practice. The only area of healthcare where that kind of norm occurs still. There's a resistance to protocols. There's an idea that somehow these things are not sensitive to the particular needs of that child or that family, or that's not the way I work. That's considered an acceptable explanation as to why one would not use things that look like they could work, and that people don't have to justify their use, and that they get paid the same, again, as somebody who is using effective programs. A major issue is that there's no prevention delivery system in this country. There are prevention programs, there are prevention offices, there are prevention advocates, but there's no prevention system. There is a mental health care system. It's not very good, but there is a system. But there is no system for prevention delivery. And so, of course, there's no place for this to grow. There's no place for this to be where it's naturally done. We know some things about what will work in general beyond these programs. Contrary to what we thought when working with children, structured, directive, goal-setting, goal-oriented programs work better. And in fact, parents like it more. People were very worried that parents wouldn't like this sort of task-oriented work. And the consumer reports to me, as well as observations from the researchers, are that people feel like, okay, we're working on something. They're here to help. I know where we're going. I know how to participate. That it should be problem and skill focused rather than global and general and related to sort of, let's talk about what's bothering you this week. It has to be kind of focused on specific problems. Turns out people come to get help for specific things, not just to have an interested person. We've now realized that. Third is that the protocol is important. It's not a nicety, it's not an imposition. It's actually very important in whether or not the impact will occur. Some of those programs I've shown you have studies that show that if you don't follow the program, they actually hurt, even though you think you're doing the same program. If you follow the protocol, it really makes a difference. And actually that research was done right here in Washington. That fidelity, that is getting people to follow protocols, expecting people to follow protocols. And whether you're a consumer or a supervisor or a teacher or a provider, it's important that you expect people to follow these programs. And that expectation should be supported. Even the programs that are not family focused work better if they're family based, because children come in families. And families see children as their concern in their province. And so cooperation and support, and whether that's cooperation meaning that they bring the child to the group, or it's cooperation meaning that they're in working with you, or it's cooperation in terms of their parents are being supported to help do what they need to do, the family being engaged is a critical part of this. That both the personal and technical skills of the providers are important. There used to be this idea of what was called a general factor, a G factor. If you had a certain warmth and empathy and feel for people, you were a good intervener. And people said, you can't overcome that. That's what comes out in the results. Well, it turns out that when one starts to measure that in some detail and technically, there are some real important technical skills, as well as an ability to feel and be interested in people that is important in engaging them. And engagement is not just talent, luck, et cetera. It's not just hiring the right people, but these things have to be trained in. And I mention these things because as we go from what can work and what's not being used to what could work, it starts to become a question of how are we going to do this, given that we're not going to have all the resources, we're not going to have all the training programs we need, we're not going to have the service providers we're going to need. We're going to have a system that's going to need to operate with the current service providers and capabilities that we have. Those characteristics get more and more important as you're talking about managing a system of providers and talking about prevention systems where the people doing the frontline work are going to need guidance and are going to need direction rather than being able to operate as autonomous professionals. So some significant limitations of what we do know. For most approaches, we don't know how they work. That list I gave you, we have some ideas, and there's some work that's been done, but for a lot of them, they work, but we just don't know why. It's what's called the black box problem. Second, we don't know what is necessary to get people to follow programs and what we need to do to structure it so that they can. We don't know if it's about enough supervision or enough opportunity to get feedback on their performance. We just aren't quite sure about it. We're developing ideas about that, developing training programs that are empirically based, as well as providing support for empirically based programs. As I mentioned, we don't know quite how to structure service training, program delivery, and management of the system given the current workforce. In Illinois, the most likely provider of mental health care for children is somebody with a bachelor's degree. And that's true, I think, in many states. So you have a situation where if that's the workforce, rather than waiting for this new group of professionals to show up, how do we make sure we can provide these services under those conditions? We're not clear for whom these interventions work. Even among these very effective interventions, and some of the most effective interventions, really looks like at the top, it's about 60% of the kids are benefiting. So there's 30–40% of those kids who are getting an intervention. It seems to work pretty well if you look on average. They're really not benefiting. So there's something that's going on with those kids that they need a different intervention, or the intervention may need to be changed. And then, of course, we need to consider group features, including what's called cultural competency and the role of culture and subgroup characteristics and understanding what can work and what can't work. We're also starting to understand that these interventions don't occur in the sense of you go in and you get them and then you're cured. No more than if you go to the doctor for the flu, that means you will never have heart disease. There are things that go on, and development is a complex interaction, and risk is a transactional. And so we need to understand how these interventions interact with ongoing influences on development. We need to understand the difference between helping people to learn some of these practices versus having people have a set of programs that they know how to follow. And there's a great debate about whether that's where we should be going, which way we should be going in that. Again, how to train up this workforce to go to scale. If we were able to get the opportunity to provide these services, how would we train up that workforce? How would we get them ready to do this? What are the systems that are needed so we can deliver the prevention programs that are so promising? So we're in a situation where we have a little bit more work to do. This unfortunately represents too often the meetings that we have when we're working on these issues, where we have a little bit more work to do. But there are some resources out there, and if you have further interest in this, for whatever reason, there's several places that you might want to contact. There's the Society of Clinical Child and Adolescent Psychology maintains a web page of evidence-based practice, empirically proven programs. There's a Blueprints for Violence Prevention, which is a board set up to look at and review violence prevention programs and identify those that have empirical evidence of being effective and are ready to be used. There's what's called the Campbell Collaboration, which is a group that takes and synthesizes all the studies and says, across the different studies, here's what we know works and doesn't work, and they can provide you information about that. And then there's the Washington State Institute for Public Policy, who is commissioned by your legislature to regularly do evaluations of what works, and they put out very readable and very usable reports about what works in different areas. And in fact, right now they're working on one for child mental health that should be out in another year. They need that long to get through all the literature. So there's very much promise here. There's still much more to learn, and there's some resources for doing that. It just is a matter of continuing to try and focus on it and bring this into the primary focus that it should have, given the impact it has on our society and the need that it shows. Thank you.
Stay here, Todd. So thank you, Dr. Tolan. We have time for a couple of questions if you want to move to the sides to the microphones. And I'll take first question over here.
Well, I think it's probably more of a comment than anything, but as a state social worker whose children are largely in large mental health agencies, far too many of our children are being treated by interns. And it's probably a nasty thing to say in a university, but I think when you were talking about training professionals and having professionals work to standards and having them, stick to standards and stick to protocols, first of all, we got to get past students treating, in many cases, some of our most severely impacted kids. And how, as a mental health system, do we fund agencies sufficiently to have truly trained clinicians? Or if there are students there, that those students are being fully trained and fully supported to implement these protocols and become the next generation of clinicians, instead of most of those agencies relying upon students to do the work because the system isn't funded.
Mm-hmm. Well, I think just to respond, there's a couple of things you've said that I think are very important. One is that students are being trained to start to follow these protocols, and the agencies are supporting those protocols in their use, and so that if whatever is being delivered is likely to make a difference. And the second, there's some greater connection between training programs and these agencies and what's going on with the students. And then third, of course, is that there's adequate support for people to be able to do this once they've finished their training, and to support the positions in such a way that they're supportive. They have salaries, for example, that are more than what students might get.
Well, thank you very much. Thank you. Join me again in thanking our speakers, Dr. Tolan and Dr. McMahon.